So good morning. Over to you, Professor.
Hello. Kamba, you saying something?
Yes, please. Please go ahead. Go ahead and start the session, then I can come in with the presentation.
Okay, so here we are. I think the others will join us later, but I want to start by thanking you all very much for making it up to this moment, to this session of ours. I know you're familiar with the session title, so I will not go over that, but the paradigm is really that despite many effective medications for NCDs, such as cardiovascular disease and diabetes, it is not likely that low middle income countries will meet United Nations Sustainable Development Goal 3.4 by 2030 of reducing premature mortality from NCDs by 1/3. So with the critical shortage of healthcare workers, interprofessional collaboration within the health sector is critical. We know that. Pharmacists, we all know, remain a highly trained and underutilized resource in most of these countries. Appropriate and equitable access to quality medicine is a key challenge in achieving and improving morbidity and mortality. So I want to add that pharmacists remain very well trained, but today's pharmacists are not well positioned to improve access to quality and affordable medicines, but to also positively impact patient health outcomes from NCDs. So education has evolved worldwide to train pharmacists with the skills to provide pharmaceutical care, and evidence from research has shown that pharmacists contribute significantly to the screening, prevention, treatment, and monitoring of NCDs through services provided such as medication therapy management. So the goal of this panel presentation and discussion thereof is to provide the audience with an overview of pharmaceutical care role of the pharmacist and explain innovative approaches to improving access to medicines and patient outcomes from NCDs. I want to move on to state what you may know right now of the session objectives. One is to describe the current burden of NCDs and challenges to improving access to medicines and patient health outcomes. Two, to explain the pharmaceutical care role of the pharmacist as a key component of the team-based healthcare solutions for the management of NCDs. And three, to describe innovations in pharmacy education and community engagement in healthcare programs that will address, improve access to medicines and address the challenges of NCDs. So at this point, I would like to very formally introduce you guys. I want to introduce myself. I'm Richard Odoye-Dome. I've been here at Makerere University for nearly 38 years. And I started the program of pharmacy in 1988. So I'm the chair, or called the host. So much of introduction, I will leave you to, it is there in abstract book, so you can read out the full length of your CVs. So I want to move on to introduce Joycelyn Shiva. She's a big person, Vice President of the African Pharmaceutical Forum of the International Pharmaceutical Federation. And she's from Zimbabwe. Joycelyn, most welcome.
Thank you.
Move on to Karen Beth, whom I have known for more than 10 years, I think, Karen, since 2011 when we met in Kampala. And she's a professor of pharmacy practice Binghamton University School of Pharmacy and Pharmaceutical Sciences, New York, USA. Welcome, Karen. The next person is Dr. Susie Crowe. I've also met her maybe 1 or 2 times, definitely in Eldoret, and she has been coming to Barara as well. Susie is Director of Experiential Education at East Tennessee State University and an alumni of the Global Health Residency with Purdue, Kenya partnership with Moi Teaching and Referral Hospital. The next person is Imran Kayanji. I think I met Imran also in Eldoret, a pharmacist at Moi Teaching and Referral Hospital, Eldoret, Kenya. Then I move on to Tina. Tina Tran is an alumni of the Global Health Residency with Purdue, Kenya partnership with Moi Teaching and Referral Hospital, and Fogarty Fellow, Philadelphia, USA. Tina must tell you that I was in Philadelphia 2006 to 2008 doing medical fellowship program. And James, yes, thank you. James Akiroga Amisi is MDCHB, the odd person here, but we welcome you very much, James. And James is the family medicine physician and lecturer at Moi University School of Medicine, Department of Pharmacy. Department of Family Medicine. Sorry about that, pharmacy. Pharmacy is my thing. Now, it is also bridging income generation through provision of incentives for care and that thing you call big picture. I think you call it big peak program, Eldoret, Kenya. We want to hear about that. And finally, Opio, Honorable Dr. Samuel Opio. Opio, are you around?
Yeah, I'm around. Sorry, I'm trying to connect through my video, but it's having some challenges, but I'm in.
Oh, you're welcome. Yeah. Welcome. We talked yesterday and I was worried you would not be around. Opio is the long-term secretary of Pharmaceutical Society of Uganda and currently is a member of parliament. I knew Opio was going to come to that and is the guru of policies. Now he has come into the real thing as policy making and advocacy. And finally, not finally, really, Dr. Kamba is current head of Department of Pharmacy at Makerere University. Kamba received his B.Pharm from Makerere University, and he got his PhD from Michigan State University, USA. And his passion is cellular and molecular biology. And finally, we have our own, she's my daughter, is Winnie Nambatia. I think she's somewhere in the background. She's coordinating us. So guys, you're very most welcome. That's the introduction, but now I want to call upon Kamba to take us through his presentation at NCDs, upgrade or NCDs in Uganda. But before he does that, I want just to warn ourselves that we have just about 1.5 hours. Exactly 90 minutes, just like the football match I was watching last night. I think most of them are 90 minutes. So ours also 90 minutes. Each person will be allotted, when you're asked to speak, I think 6.5 minutes, and then we leave the rest of the time for our discussion. So, okay, Dr. Kamba, please come in with your presentation. I can see you already have something on the screen.
Okay, thank you so much, Professor Doi and all colleagues and panelists. This presentation is just a prelude to the main panel discussion and to give an overview of non-communicable diseases.
Kamba, can you talk a little loudly, more loudly than that?
Okay, thank you. Let me try. Okay. Yeah, so this is just to give sort of a prelude to the main discussion, and I will take you through the overview of the burden of NCDs, both globally and locally in Uganda. I should do this in about 3 to 4 minutes. Basically, that's the outline of the presentation. So, as we may be aware, NCDs are those diseases that are not passed from one person to another, and they are typically chronic and of genetic, physiological, environmental, or behavioral etiology. There are about 5 broad groups: cardiovascular diseases, diabetes, cancers, chronic lung diseases, and mental health. Now, globally, NCDs are the biggest killers of human beings. About 71% of the 57 million global deaths are accounted for by NCDs. And what is shown on the right, it shows the contribution of each major group of NCD global death. Cardiovascular disease, obviously, and cancers stand top there. Now, of all the deaths due to NCDs, about 80% are actually in low and middle income countries. Now, Uganda, but NCDs are rising in Uganda. As you can see here, raised blood pressure, the prevalence of raised blood pressure is about 20%. So there's a high burden of actually heart disease. The prevalence of raised blood glucose is about 3%. And all other indicators of NCDs are actually very high or on the rise. Now, in terms of mortality, 33% of all deaths in Uganda are accounted for by non-communicable diseases. So it is a big problem, although slightly lower than the overall burden in low and middle income countries. It is still high, and basically it is bogged down by the high mortality from infectious disease. So, what are the actions, healthcare actions against NCDs? Of course, some NCDs like cervical cancer or pharyngeal cancer, which have a viral etiology, there is now a vaccine. But most importantly, education and regulation, among other things, are critical to the prevention of NCDs. As you may be aware, a lot of these are actually difficult to implement. Most patients almost always end up under the care of healthcare workers. In that instance, you need timely detection, effective treatment, and occasionally palliative care. There are some challenges though. As we are aware, NCDs typically coexist with one NCD exists with other NCDs, and typically they exist with infectious diseases. That makes treatments complex. Also, it happens that some of the treatments for NCDs have low therapeutic index. So there's a very narrow margin of error. It predisposes to drug interactions, toxicity, and introduces adherence problems, among others. The other major challenge is because they are chronic, they often need chronic treatment, which again brings in the element of high cost and adherence. And of course, some of the diagnostics are also complex and costly. So what can we do as pharmacists? Of course, by virtue of our training, pharmacists work with and for the patient to optimize outcomes of care. This, the new phenomenon called pharmaceutical care. Among the things pharmacists can do is finding and responding to drug-related problems as members of the healthcare teams. Now, pharmaceutical care is a patient-centered approach. The emphasis is on the patient and tailoring treatment to individual patients. And it also emphasizes a cost-effective approach to patient care. Okay, so that was the appetizer to the panel discussion. We have already done introduction of panelists, and Professor Odoi has already gone through the ground rules, especially the time allowed for each panel discussant. Over to you, Professor Odoi. Thank you so much.
Thank you very much, Dr. Kamba, for your introduction, for your NCD. Now I know something about it, position in Uganda. And this, I think, our our neighbors, Kenya, Eldoret, I think probably you're seeing the same thing there, like in Uganda. Maybe the different thing from the one in USA. Well, let me now move on to the second speaker, and that is no one other than Vice President Shiva. So Joycelyn, you are representing the African Pharmaceutical Forum within FIP.
Yes.
I would like to ask you to describe the mission of FIP and explain how the pharmaceutical care role of the pharmacist is different from that of the dispenser role. Related to that, I would want to ask you what initiatives FIP is involved in to help improve patient outcomes from NCDs. So Joycelyn, there you are.
Thank you. Good morning. Thank you for the invite so that we can share our perspective as pharmacists and from the regional and international level in terms of NCDs. First of all, I think the introduction was quite clear on what NCDs are and what is the objective in managing and preventing NCDs. So FIP, from the perspective of FIP, in 2018, FIP came up with a program whereby we are saying pharmacists through international organizations, our objective is to improve access to pharmaceutical care services. We know that pharmacists are very accessible. From where I come from, someone can just walk into a pharmacy and they can get the help they want, be it for treatment, be it about their medication, or even prevention. It's because pharmacies are accessible and there are so many pharmacists around the world and they are being underutilized. So FIP, in 2018, there was the Astana Declaration on a primary health care, which highlights the need for greater investment in disease prevention towards sustainable or sustainability of health systems and the achievement of universal health coverage. This is particularly important in relation to NCDs, which are to a great extent are associated with preventable risk factors, because we always say prevention is cheaper than cure and it's more effective because treatment becomes even more very expensive. And when we have NCDs, it's a lifelong treatment, it's expensive, and in most of our countries, it comes from the pocket. There's no medical insurance. So it is very critical for people to have a preventive systems in place. So the results of this program will provide evidence of the crucial role of pharmacists in reducing global burden of NCDs. And as a FIP and through our associations and the African Pharmaceutical Forum, we're encouraging our associations and to actually engage with educators so that the pharmacist becomes also more confident about their role. And then we don't just spend a lot of our time just on giving out the medicines, which then become useless in the end because the patient doesn't know how to use them. Sometimes we spend a lot of time sourcing the medications, and then at the end of the day, it is not of any use at all. So pharmacists should also become more confident and make use of their knowledge. The product is there, but when it's not used properly, then it becomes a waste of resources. And these are very scarce resources we're talking about. So as pharmacists, we're encouraging that as associations, we should link or work together with our governments, which are the policymakers. We should work together with the regulators. We should work together with the schools of pharmacy and the professionals themselves, so that at the end of the day, we actually have better outcomes to help the patients and make sure that the medicines, which we are taking so much time to develop and so on, become effective. And adherence is one of the issues which always comes into play. Sometimes the patients don't adhere because they don't understand how they're supposed to use their medicines. So in terms of NCDs, it is important for the people to know that they should not just stop. What comes to my mind is with someone with diabetes, when they're feeling better, they sometimes just say, oh, maybe I'm feeling better, I should stop. Or high blood pressure, hypertension. The person feels better. And from where I come from, we always say hypertension is a silent killer. It's because it's not painful and people respond better when they're in pain. But we have to tell them that even if you are not in pain, make sure that you have you manage your NCD properly, be it diabetes, be it hypertension. With cancer, sometimes it's not painful, but when it's painful, they sometimes just focus on just the pain management and not deal with the other medication. So pharmacists have a very crucial role to play to ensure that medicines are properly used. And as FIP and African Pharmaceutical Forum, we are talking to our associations so that some of these things are embedded into our education, and even as continuous professional development, we ensure that our pharmacists, they know that they continue counseling with the patient, and new things are coming up. There's a lot of innovation which has also been coming up, which we should embrace as pharmacists to ensure that patients get the best out of our very valuable services as pharmacists. So it is very important for pharmacists to work together also with other healthcare professionals. What comes to mind, excuse me, is when we are managing something like diabetes, a patient is being seen by their physician. But for continuous management, there's need for that interprofessional collaboration to ensure that the patient gets the proper prescription, the pharmacist helps with the management and monitoring together with the prescriber, and also together with the patient themselves. We should never leave the patient outside the circle of all this. They should be part and parcel of the management of their own systems. So pharmacists have a very critical role to play. And that, when we talk about collaboration from everyone, in the supply chain, the prescriber, the dispenser, not just ending with dispensing, but ensure that what you have dispensed is properly used. As pharmacists, we have a big role to play if we are going to achieve universal health coverage as per our SDGs. Thank you.
Wow, thank you so much, Joycelyn. That's why you're president, you're vice president of FIP. Last time I was with FIP, we used to talk about 8-star pharmacy, 6-star pharmacy. I don't know whether we're now 15-star pharmacy. You're definitely 15-star pharmacist.
We try.
I like that one, pharmacists having confidence and to play his or her role. I think that's what we lack in terms of pharmaceutical care in Uganda. So now I want to move on to Professor Bohan. As I said, I met her 2011. That's when we started talking to each other. And since that time, I've known her as Karen Beth, if you don't mind saying, she's a go-getter. And she will get anything she wants. So, but I want to ask you, Karen, I know you've been with us for that long time. You've been collaborating with our department for the last 9 years, in fact, 11 years, to build capacity from pharmaceutical care, skills training. I remember we took about 3 people to USA and they have disappointed us, but we're logging on. What educational innovations have been enacted to equip pharmacy students with the necessary skills to improve NCD? Up to you, Karen.
Yes, thank you so much. I'm very pleased to be here today. Greetings from Binghamton University in New York, where it is currently 2 a.m. or 2:30 a.m. on this side. Anyway, as Professor Adori mentioned, I've been bringing pharmacy students from America to work with pharmacy students in Uganda for a number of years. and realized that although our curriculums are very similar, the practice of applying those skills, the pharmaceutical skills, the kind of things that Joycelyn mentioned that are needed to make improvements in patient healthcare, that was weaker in the curriculum. And so the professor and I realized that I could help with that. And in 2014, I got a Fulbright specialist grant to come to Uganda to do a needs assessment to figure out what the curriculum needed to have built, and then also then to come back several times to help them build a pharmaceutical care skills lab. And so this training equips the pharmacy students at Makerere to have those skills needed to interact with the patient and to work with the healthcare providers and the medical team to see better patient outcomes. Some of the things that we teach are how to systematically evaluate a patient's symptoms or complaints, how to talk to a patient appropriately, how to figure out if the result is because of lack of adherence, not able to afford the cost because the clinic ran out of the medication and they can't afford the medicine at the pharmacy. Maybe they like traditional medicines better than Western medicines, and so they don't take their medication. So we teach them about that. We teach them how to evaluate laboratory tests to monitor drug therapy, to make sure the patients are getting the outcomes desired. So for example, for high blood pressure, we teach them how to take blood pressure so they can monitor patients, or with diabetes, do finger sticks to see what the blood sugar is, or drug therapy management if you need to monitor lab tests for the drug therapy. We also teach how to evaluate a patient's medication profile on their medical chart to figure out what's going on with them right now, and are they on safe and effective drug therapy? And if not, identify any kind of drug therapy problems. And then we teach them evidence-based medicine and how to use medical and drug resources to solve those problems. And then we bring those to the clinical practitioners, the physicians, and the other people we're working with. I'll give you an example of a time that I was at the hospital working with the medical team with the pharmacy students. And we saw a patient who was on 3 different blood pressure medicines, but their blood pressure hadn't come down at all from when they were admitted to the hospital. So the students used their skills of talking to the patient and evaluating their complaints, and found out that the second drug was ordered even before the first drug had been given, because the first drug was ordered after the pharmacy closed on the day of admission. The third drug was ordered after only 1 dose of the first drug. So basically the patient hadn't even responded to the drug therapy when the new drugs were being added. We were able to bring this to the physician team, and thereby helping that patient avoid an adverse effect of having too many blood pressure medicines. These pharmaceutical care skills can be used by pharmacists in the clinic setting, outside of the hospital, to manage non-communicable diseases. At Binghamton University, I want to tell you about a few colleagues of mine who are what we call ambulatory care pharmacists. They work with physicians in a clinic, and they work under what's called a collaborative practice agreement. That's a document that the doctor and the pharmacist write up together that says what the pharmacist is allowed to do for the patients that the physician refers them to. So sometimes they order lab tests, sometimes they change the dose of medications if it's appropriate, sometimes they order new medications. But 2 of my colleagues work specifically with diabetic patients, patients who have hypertension, cardiovascular disease, lung disease. Another colleague works with pain management, so helping patients get the most from their pain medicine. And another one is a psychiatric pharmacist who works with mental health patients that are referred to him because they are either non-adherent, having side effects from medicines, or they're just not responding appropriately. Pharmacists are able to spend a lot more time with the patient using these pharmaceutical care skills to get to the nitty-gritty problems behind the drug therapy, and then make recommendations back to the provider about how to manage those. Together, we can all help improve the patient care outcomes when we all use our own specialized skills and work with a medical team. Thank you. I'll pass it on to the next person on our panel.
Thank you, Karen. Just to the time, thank you very much for keeping that time. Now, I would like to straight away go to Dr. Crowe, Susie, as I said, I met you in Eldoret, and I know you spent there 3 years working with the Purdue University Kenya partnership at Moi.
Sure.
Please.
Thank you very much for the introduction. So I'll go ahead and get started. And thanks also for the opportunity to speak today. So what I wanted to talk about is a little about my experience working within the clinical pharmacy training programs from 2012 to 2016 in Eldoret, Kenya, through the Purdue Kenya partnership and also the Empath Consortium. I'm the first person from the Empath Consortium talking, so I thought I might just give a brief introduction of what that actually is. So Empath began in 2001 as a partnership between Moi University, Moi Teaching and Referral Hospital, a number of North American universities, including Purdue University, which is where I trained within Kenya, and also Tina as well, and then the Ministry of Health. The motto, I guess, for Empath is leading with care. So meaning the focus is primarily on improving patient care, and all other things such as teaching, training, research, all of those things revolve around improving patient care. So patient care comes first and those things follow. The Purdue Kenya program includes clinical pharmacists and faculty from Purdue, also from Kenya, that have had a sustained presence in Eldoret, Kenya since 2004. I was actually with the program from 2012 to 2016, so several years after the start of the program. My goals, and you'll hear from Dr. Tran here in just a minute, my goals were very different than hers. So we had very different focuses, but both working within the same program. My goals were working on building clinical pharmacy services within Kenya, within internal medicine, and also within a cardiac care unit there that was newly formed, and also on building clinical pharmacy training programs in Kenya. So just to talk about one of those things, so with the cardiac care unit, the Duke University led cardiac care unit first opened at Moi Teaching and Referral Hospital in 2013. I worked within the cardiac care unit to develop infusion protocols, improve patient safety, trained nurses and staff on how to use those protocols. I also worked to build a sustainable supply of medications within the unit. Worked with Dr. Manji, who's on this call, together to work on that. While I did that, I was also working on incorporating pharmacist rounding within the physicians and nursing team in the unit. I also had a patient care focus in all of my activities. But while I was doing those things, I was able to train both Kenyan and American pharmacist learners alongside me as I did it. And I think this is just one example of how leading with care leads to the development of education and training programs, which I think is important for students to learn from those types of experiences. Another example of where important infrastructure was built by the Purdue Kenya program to meet a patient care need is anticoagulation management. So the Purdue Kenya program first conducted a needs assessment to identify the need for anticoagulation management. With rheumatic heart disease and a number of the conditions that happen, there's definitely a need for anticoagulation. After that, anticoagulation services were developed for patients. And then the anticoagulation clinic was the outcomes of patients and the benefit of the clinic was reviewed and showed to be very similar in outcomes for patients to programs that exist and have existed for a while in the United States. So it had great benefits for the program. Another one is diabetes management programs, which were developed to address barriers to patient care to diabetes. And were actually shown to have significant decreases in the hemoglobin A1C. And again, the anticoagulation and diabetes management services are important clinical pharmacy education opportunities for students to learn from, hopefully multiply those types of experiences elsewhere when they move on and outside the program throughout the country of Kenya and Uganda or wherever. And so those types of learning opportunities are great ways for students to expand clinical pharmacy care throughout the country. Just a quick summary of the clinical pharmacy education and training programs in Eldoret. So there's a Kenyan pharmacy internship program where students come and spend 6 months worth of internship. Over the years, I believe since 2008, there have been at least 80 interns, and I'm sure more than that even, that have trained during those 6-month internships. There's a year-long pharmacy residency program that started in 2011. I was a resident actually in 2012 and stayed on afterwards. So there were Kenyan and American pharmacists learning alongside each other. There's a postgraduate diploma program that began in 2016, and then a master's of pharmacy and clinical pharmacy, which is a 3-year training program that began in 2017 at Moi University. My role was primarily providing foundational clinical knowledge, giving students plenty of opportunities to practice, which I think is key, not just learning in a classroom, but actually getting out there in the real world and getting to practice those skills, and providing lots of feedback to improve their clinical skills throughout. On many of these experiences, the Kenyan learners were learning alongside American learners. And I will say, while America prides itself on the pharmacy education and PharmD education and the clinical education that students get in the United States, our Kenyan pharmacist interns were actually shown to provide more volume of clinically significant interventions over time for NCDs and otherwise than the American learners. And so I think that's important too, when given the opportunity and given the clinical skills and the opportunity to practice them. Our Kenyan pharmacist learners were making a significant impact on clinical pharmacy in the healthcare system. So I just want to end with saying, without a doubt, it's been mentioned by other people speaking on here already, but the healthcare systems in Kenya and Uganda, where I practice, have faced many challenges: shortages of healthcare workers, supplies, drugs. Pharmacists are often faced with the dilemma of stockouts and medications, and pharmacists with a clinical skill set are able to take that patient's diagnosis, make a recommendation that's equally effective, for an in-stock medication, for example, ensure patients receive continual care, which is very critical within the healthcare system. And then finally, within the American healthcare system, clinical pharmacy has been proven to improve health outcomes. I believe pharmacists in sub-Saharan Africa, in my opinion, are underutilized, and it sounds like dependent of other people on this panel as well, but they have potential to play an even greater role within the healthcare systems in sub-Saharan African countries where non-communicable diseases and communicable diseases are prevalent, and the prevalence is growing. So with that, I will end.
Great. You know, Susie, it's so inspiring to hear you talk about this thing. And especially when I know that you're also you're sharing your skills with Sister University and Mbarara University. I'm
Yes.
sure one time or another you come to Makerere as well. But I'm just happy that you're in Mbarara. Yeah.
I would love to. Thank you.
Entering our human resource. Thank you very much, Susie.
Thank you.
Now I want to move to Dr. Manji. Dr. Manji.
Yes, I'm here.
Yes, I know you're the principal pharmacist at Moi Teaching Referral Hospital. I've been there. Met. I want you to please describe the program, the big pick. No, not the big pick, but tell us about the clinical pharmacy unit. It's also known as Center of Excellence for the clinical pharmacy at the hospital, as well as that revolving fund, the revolving fund pharmacy program you and your pharmacists are involved in. And that is improving patient outcomes from NCDs, the revolving fund. What is it? I'm just so eager to hear that. Manji, take over from there.
Thank you very much. I think Susie has covered a lot as far as the MTRH, the Purdue Kenya Partnership Program is concerned. I just to give you a bit of a background. So I have been with MTRH, that's Moi Teaching and Referral Hospital, since 2008. So just as the Purdue Kenya Partnership was picking up, I essentially have worked very much hand in hand with the faculty from Purdue Moi University and MTRH to bring up this clinical pharmacy program. So my background is I'm a pharmacist. I'm Kenyan, and so I'm an employee of Moi Teaching and Referral Hospital, and I currently lead the clinical pharmacy program there. I've worked with Susie and Tina, who's going to speak after me, and many of the other faculty from Purdue to bring up these programs. So essentially, I'm not going to repeat what Susie has talked about because she's pretty much in a broad sense covered everything that the clinical pharmacy program at MTRH does. I will add that one of our to the goal that yes, patient care is our primary goal, but the other goal that I would add is that we are very much focused on building future leaders in pharmacy within Kenya and East Africa, and through our training programs. Susie mentioned the residency program, which one of the lessons that we learned very quickly was that, yes, it was an American style program that we had to adapt to Kenya. And as far as regulators are concerned, the Pharmacy and Poisons Board in Kenya did not recognize like a residency. And so we had to quickly change the program and get it to become a postgraduate diploma in clinical pharmacy that's more of an, it has an academic look to it, but principally is the same in terms of the teaching that we provide, the education, which is more experiential compared to like a traditional diploma where you would be in a didactic classroom and be learning in class. Our programs are primarily, bedside, working with the patient and working to improve not just the patient care, but now the knowledge that the pharmacist has when providing the service to the patient. And I will add also that many of the graduates of these programs, from the residency to the internship to the postgraduate diploma and now the master's in clinical pharmacy, are now leading programs of their own within our hospital. And so, they're leading their own services. And so we have pharmacists specialized in different areas of practice within Moi Teaching and Referral Hospital, which is one of the largest referral hospitals in Western Kenya. It's the second largest hospital in Kenya, serving about a catchment population of about 24 million and about 23 counties in and around Western, Northern, and Southern Kenya. And so these specializations are very important. Susie mentioned like the cardiac care unit, which she helped build up. And the important thing was that, after she left, we have a clinical pharmacist who's leading that area of critical care and is continuing to provide the education to future pharmacists, but also making sure that the care continues and patients are receiving the best possible care. Other areas, she mentioned anticoagulation. We now have pharmacists in the ICU. We have pharmacists in the surgical areas, reproductive health, pediatrics, oncology, HIV. So all of these areas, have clinical pharmacists running who we have trained within these programs. And so the important message I would say is that while we are building all of these education and research programs, our core focus should always be on how can we build the infrastructure for clinical, not just clinical pharmacy, but overall patient care systems, so that we are meeting the needs of our patients and the needs of the institutions that are managing these patients. And not just focusing on the research aspect or the education aspect, but building these together with the aim that we are going to improve patient care, but also build the future leaders of pharmacy. Then segueing to the Revolving Fund Pharmacy program, which is slightly different from clinical pharmacy, but I think it's very well linked to it. Empath, as Susie mentioned, works in the community as well. So not just a tertiary referral hospital, but Empath has a presence in over 500 health facilities, ranging from the lowest level, which is a dispensary, all the way up to a health center, and then previously known as district hospitals. We have now sub-county, county hospitals, as well as and then the referral hospital. And so when Empath was changing its focus from HIV to being more of a overall healthcare provision, and especially with relation to non-communicable diseases, as we had our presence in these facilities, we quickly realized that there is no way that we can carry out any NCD related program without essential medicines being available. So when we went in, this was in the early 2010s, we found that most public health facilities have availability of less than 30% at any one time of essential medicines. And it was worse for NCD meds, which I would say is almost like 0%. And so and we realized that it's an ethical conundrum, because you can't go in there, screen thousands of people for hypertension, for diabetes, for cancer, and then tell them that they have this condition that we can't really do anything about because we can't provide them with the medications. They're not able to afford them in the private sector. And the government facilities which they rely on don't have the medications available. So what we ended up doing is creating this model where we would have a pharmacy within a public health facility that would serve as a backup to the public health facility pharmacy. And so patients would essentially be able to purchase these medicines at a very subsidized cost if the facility pharmacy doesn't have the drug. And then the fund, basically whatever is collected, would now be used to restock the drugs at the facility and make sure that patients do not leave the facility without medications. So these currently we have a presence in about 95 health facilities, and we've had to modify the model depending on the type of facility and the level of care and the volume of patients that we see. But right now, because of this model, we've been able to ensure over 90% availability of essential medicines, and specifically for chronic disease drugs, for hypertension, diabetes. And this program has been able to support many of the other Empath programs, including our NCD programs, as far as at the level of the facility, but also at the level of the community, which the next speaker, Tina Tran, Dr. Akiruga, will talk about, which is the Big Pick program. At the level of community health groups, we're able to support medication access, and it has really changed the way we manage chronic diseases and NCDs at the lowest level of care. So I can talk for hours about RFP, so I want to stop there. But maybe later on, if we do have time, and if anybody wants to reach out, I can talk a little more. And I've published quite a few articles in peer-reviewed journals about the RFP program, and you can have more details from there. So back to you. Thank you.
Good. Thank you very much, Manzi. And what you're doing is really excellent, because quite often we simply go to classroom and academic. But now you're looking at building future generation leadership. And I like very much that thing you talk about, negotiating politics of recognition. That's excellent. Thank you very much, Manji.
Thank you.
Now, I want to move on very quickly to Dr. Misi and Dr. Tran. I'll put you together, but I'll give you the same question, but slightly different, and I will say what the difference. Now, I know you work together on the Big P program, family program in Kenya. I want you to describe this program, and some of the positive patient care outcomes that have been made possible through the program. I want Dr. Akiruga will provide overall description of the program, his vision, and few details of how the program is operated. While Dr. Tran Tina will provide data on outcomes observed thus far from the program. So let me start with Dr. Misi. Take it on.
Thank you very much, Chair, Dr. Richard Adome. I am privileged to speak about the program and to have worked with Tina and many others behind the scenes whose names are not mentioned, but we are basically going to talk about what me and Tina and others have worked on. So I'm going to provide a description of the overall program, the vision and how the program is operated. So thank you very much, Chair, for the chance. So bridging, BIGPIC stands for Bridging Income Generation with Group Integrated Care. And I co-lead this program with Tina Tran, who is a pharmacist. We work synergistically and we have worked very well on the program since we began. The program is built on the principle that addressing health and wealth needs of our population in one package can lead to a powerful and synergistic impacts. And we're going to be demonstrating this as we go along. And the second principle that we work on is that beyond health and healthcare, social determinants of health play a large role on impacting overall health outcomes and inequities. This is an innovative service delivery program that is designed to address some of the social determinants of health responsible for health inequities. As you may understand, social determinants of health are conditions in which people are born, grow, live, work, and age. You heard a lot about the Empath program, and so we operate within the big umbrella of Empath, of the Empath program. And so I'm going. I want to thank Imran Manji and Dr. Sui for explaining how the Empath program works in detail. That makes our work easier. The program is based in Western Kenya. Kenya is divided into counties. We work within Bungoma County, to be specific, Webuye West Sub-County. It began on a pilot model in 2016, and it's been running for the last 5 years. We use paper-based documentation of visits of patients in the group activities. And we also have an electronic medical record system that is connected to the rest of the Empath system. We do group care activities, and the group care activities, we have a clinical officer who is a lead person who goes out together with a pharmaceutical technologist, community health volunteers, and group empowerment service providers, whom we essentially call GESPs. They play a very big role in terms of the SME aspect of putting people together and bringing their monies together to achieve certain objectives. We do monthly scheduled clinics. We also do drug deliveries when we are not able to do the clinics. We also participate in community screening events and education events. We work within the Milo community, and this community is composed of approximately 15,000 people within the sub-location. The intervention basically is that BIGPIC utilizes community-based microfinance groups as a platform to deliver portable care. And it is designed on the FLTR model, which is essentially find people with problems, link them to care, treat them, and not just treat them, but retain them in care to see the overall outcome at the end. BIGPIC relies heavily on the power of community-based microfinance groups to draw members into the model. The community-based microfinance groups help to increase the wealth of members. In these aspects, we help find markets for them. Most of them are farmers. So we find markets for farm produce. We educate members on value chain improvements. For example, those that produce vegetables, we help dry them to preserve them for sale when they are out of season. We help with packaging of some of the other produce. We offer accessible health. And how do we do this? We do that by eliminating the geographical healthcare access barrier. So we bring care into the groups. So when people meet to discuss their finance issues, their group care activities, their SME activities, we also use that opportunity to check their blood pressures, check their sugars. Those who have chronic diseases like diabetes and hypertension are seen by the clinical officer. And when they are done, they continue to discuss their money issues. We also use this opportunity to address men's care. I don't know the communities that the rest of you work in, but I probably know in the East African region, in Uganda, maybe Tanzania, that it is very difficult to bring men into care. You know, if you have a chronic disease, they are likely to fail to seek care. But if you talk about money, men will be there. And so we have used this opportunity to ensure that we address men's needs because most men present late for chronic disease conditions. You may be aware of the so-called macho image of men and how that is detrimental to care, more especially of chronic diseases and specifically non-communicable diseases. And so we are able to prevent late presentation of men with chronic care diseases and also prevent complications. The forms of care that we give in the model, we do chronic disease care, so hypertension, diabetes, epilepsy, palliative care, arthritis, and we basically have these broad-based clinical teams that I described earlier. We do a very small amount of very small limited care of acute care because we work in a malaria endemic region, and so it is difficult to take care of the chronic disease conditions and not talk about the acute cases like malaria in this area. We are also involved in integrated cervical cancer and breast cancer screening programs. We have recently introduced mental health care in our team. So we are also doing mental health screening and linking them to appropriate care. We also get involved in point of care investigations, and we also do some of the complex investigations. We carry along our ECG, a portable ECG machine. We also carry along a point of care ultrasound that we use in the primary care settings to help make diagnosis. We also do the other point of care investigations like blood sugar, I-STAT6, hemoglobin A1C. Now the program has an interlinked referral pathway. So apart from the group-based care, those that require higher level care, we are able to link them to a health center where we are involved. It's called Milo Health Center. And in this center, we have family physicians visiting this center twice a month. And so referrals that need higher care are referred to this center. From that health center, we can also refer patients to the county health, which is the Webuye County Hospital, in case they require that. And we can also refer the patients all the way to Moi Teaching and Referral Health, which is a tertiary facility that caters for all our other needs when patients require to be referred. So finally, our vision is to expand the model beyond the Milo community. We also want to be able to demonstrate the impact of the program on health outcomes within the community through appropriate research and dissemination activities. we've been able to, produce some work that has been published in peer-reviewed journals from these activities. We want to expand the economic enhancement activities through appropriate partnerships and be able to grow the wealth component of our model. We want to truly expand research and education within the model. We also would like to partner with collaborators to expand care to the rest of the region. Maybe I can now welcome my colleague Tina to take you through some of the data obtained within the group that we have analyzed. Thank you very much. Again, Tina.
Thank you, James. Yeah, you really, I didn't know that it was so versatile like that, from social determinants to, making population care for themselves. That ownership is very, very important. But let me quickly, we still have some time, but I want time there for discussion, like some of the things you're saying, which I need you to expand, which I want to reserve some 20 minutes or so on our time to do that. But let me turn to now Dr. Tran. Like James said, give us some data on the outcomes observed. That's from the program. Thank you.
Thank you, Professor Adome. Thank you, Dr. Amisi, for the opportunity. So I will, I think, very quickly demonstrate some of the findings that we have been able to put together so far, and then leave some time for discussions, questions, and things like that from the audience. So as you already heard from Dr. Imran Manji about some of the work that's going on within the academic model, providing access to healthcare at Moore University, and also with the Revolving Fund Pharmacy, providing pharmaceutical care within the health facilities. And so our goal, and some of the work that Dr. Amisi described, is really to take that pharmaceutical care outside of the health facilities into the community so that the patients can get access to them in an easier fashion. The other thing that I think Professor Kamba mentioned earlier is there's this issue of affordability, there's this issue of financial constraints preventing patients from purchasing medications. And so our program really operates on the fact that, we need to be thinking about how patients will afford medications. And one of the ways we do that is through our microfinance model. And so allow me to share some data on our microfinance outcomes so far. So up to date, within our catchment area of about 15,000 members or so, we've been able to form 178 microfinance groups with about 3,862 guichet or microfinance members. And so altogether, all of these groups and group members have been able to save up to an equivalent amount of about $80,000 in total. And so as you can imagine, all of this pool of money can be used and can be circulated so that patients can take out a low interest loan to take care of their care needs, to take care of, potentially thinking about enrolling in health insurance so that they can get, medications, and they can take care of their, their other care needs without having to pay for that user fee or upfront cost. That amount of money can also be used for their social and other household needs. We have been able to show that our linkage rate and our retention rate is about 54.3% for linkage, and retention is about 56.5%. And so compared to historical data, that is about twofold increase. Basically, in the past, we've seen linkage and retention within at the facility, it's about 30% or so. And so we're very encouraged that we've been able to show that this microfinance models and patients who participate in the microfinance platform, number one, have better disease management outcomes. And number two, we've also been able to show that these patients are able to link and enroll into health insurance at a higher rate than other patients. I'll talk a little bit about, one of the newer program that we've recently piloted, which is a community-based medication delivery program. And so basically, Imran, Dr. Manji talked about, creating the supply chain system, but how do we know that even with these pharmacies and this big pick model in place, that patients are actually, getting medications in their hands and taking them? And so patients were still complaining about, difficulty accessing the healthcare facilities, accessing the revolving fund pharmacies. And so what we've decided to do is to overcome that barrier. We created a pilot program just to show acceptability and feasibility, whereby we basically package, based on patients' requests and based on review of our clinical officer, we basically package medications in brown bags at the pharmacy and then deliver them to patients to their home or at a convenient location in the community. And so far, we've been able to show that this medication delivery method improves medication adherence and also has improvement in blood pressure reduction as well. So we've only tried this in the hypertension patient population, and we're hoping that in the future we'll be able to expand that to the diabetes patient population as well. So I think I'll stop there. Thank you for your attention.
Thank you very much. Thank you very much, Tina. Great stuff you're doing there, like giving evidence and everything. I mean, you match intervention with evidence, and what more can be done? Thank you very much. Now,
thank you.
Finally, I would like to call upon my own son. I call him a son if he doesn't mind. Honorable Pio.
Thank you so much.
Member of Parliament, and he has been on these policy issues even before he became Member of Parliament. I mean, just recently became Member of Parliament, but I think he was doing much more than other members of Parliament were there before. So, Honorable Pio, what type of policy regulations changes are needed to fully realize patient outcome benefits from the widespread implementation of pharmaceutical care? Honorable, take it up.
Thank you so much, Professor. I do apologize. I'm having a technical glitch with my video, but nevertheless, I'll continue to proceed with the audio. I've been Secretary of the Pharmaceutical Society of Uganda for more than 10 years. And during these 10 years, we've had a lot of strong engagements with Professor Odoi, Professor Karen Beth on advancing pharmaceutical care in this country, Uganda, and a lot has been done. And in all our efforts, I came to learn that as much as we are working so hard on individual efforts, it is very important to have these efforts institutionalized. And that brings out the strong emphasis for the need for legislation, policies, regulations, and guidelines to be able to support pharmaceutical care. When we look at the current environment, increasing NCDs, meaning increasing demand for services, but also in an environment of substandard medicines, falsified medicines, so issues of drug efficacy, but most importantly, comorbidities, which is emerging to create not just treatment complexities, but treatment dilemmas. If you look at currently the situation with this pandemic, we are having treatment dilemmas. A patient with diabetes, hypertension, cancer, HIV/AIDS, and infected with COVID on an ICU, on a ventilator, and need to ensure that the medication management is addressed. Definitely it becomes a dilemma, not just a complexity. But we're also seeing emergency uses of medicines coming in, medicines with incomplete data, leaving a big pharmaceutical gap. So that shows clearly that the need for pharmaceutical care services is much greater than it was before. And it presents the fact that we should no longer look at it just as a pharmacist priority, but we need to make it a public health concern and a political agenda. And it is out of these challenges that even as the Pharmaceutical Society of Uganda, when it came to the general elections, we came up with what was called a P20 plan. P20 plan meaning 20 pharmacies, sending them to parliament. Out of the 20, we managed to get 8 that were nominated. Out of the 8, 3 of them were successful and are now members of parliament. That's one big achievement that we've been able. And I believe this will help us to put the pharmacist agenda, the pharmaceutical agenda on the political space, in the public health arena itself. So it is very, very critical that not just bottom level interventions, but also top level approaches are required. And I'm glad to say that out of our engagement in parliament now, I've been able to create the Medicine and Health Supplies Parliamentary Forum, which has been initiated in Uganda. We're also glad that among the 3 pharmacists, one is now the Shadow Minister of Health, from the opposition to help give alternative policy. So it is very, very important that positioning of pharmacists is also very, very key in positioning the pharmaceutical care agenda, not just in Uganda, but across the region. The second issue that we need to emphasize on, and from a legislative perspective, has been on national budgets. I have looked at many national budgets for medicines. If you look at Uganda, it's about $100 million. Next year, it's increasing to $150 million. But whenever you look at these budgets, there are only 2 cost centers. The first is the medicine, and then the second is the distribution costs or the handling costs. And the assumption is that access is completed when the medicine is received. We need to change the budgeting norms. If we can have 7% of our budget allocated for distribution, why not another 7% for pharmaceutical care? I've always said you cannot procure 1,000 laboratory instruments and think that the 2 lab technologists in the country will be the ones to run them. It is very important that the budgeting norms need to be redefined, but we also need to redefine access. I've always said that access is not complete when the medicine is received. If a patient receives the product without the pharmaceutical care service, they have not received the drug, they have received the poison. If they receive the product with the pharmaceutical care service, they have received the drug. It is very important that we redefine what access means, and we need to target to the pharmaceutical care component, such that any budgeting processes must ensure that you don't just budget for the drug, you don't just budget for the distribution cost, also budget for the pharmaceutical care cost. This is one thing, and I hope that this summit will capture this as a very strong recommendation. When we go into at the ministry level, we've seen a lot of programs for HIV/AIDS, malaria, TB, and in Uganda, we've seen that it has successfully brought out the issue of pharmacovigilance, which is a component of pharmaceutical care, mainly for the infectious diseases itself. We need to see programs established for NCDs, for diabetes, for cancer. And I believe through this, pharmaceutical care will emerge as a very strong specialized service that is needed itself. But not just on the program itself, we need to also ensure strong participation in public service review structures. In Uganda, the public service structure is reviewed every 10 years. Because of delays, it was last reviewed in 2005, but last year, after 15 years, the review has been done. And we strongly lobby to ensure that we get pharmacists, not just as supply chain pharmacists, but also bedside or wardside pharmacists who can be able to address that role of pharmaceutical care. We are glad that a draft is already in place. There are still other discussions that is ongoing, and that emphasizes the need for having a clinical infrastructure to be in place. But in light of that, we also need to have the staffing norms. How many clinical pharmacists do we need for every 10 beds, every 50 beds? How many clinical pharmacists do we need for example, 10, where there are 10 medical doctors? How many clinical pharmacists are needed? These staffing norms are needed. We need to have staffing norms. The advantage with staffing norms is they go beyond just the structure. They have a lifespan. They have a higher longevity that even when it is not implemented in the structure, the norms continue to exist, and when budgets are available, then implementation can occur. So we've been able to push that strongly. We were also able to push for at least 3 scholarships for clinical pharmacists every year. And now for the last 3 years, that has been achieved. Now we are pushing and saying, look, government, you've sponsored 3 pharmacists every year for the last 3 years. Now, where are they going to practice? You need to absorb them. You need to provide for them within the organization structure. So it is very important that at ministry level, the interventions of staffing norms emphasizing the need for them for specialized pharmacists to be supported through the scholarships, but also the clinical infrastructure for the human resource itself. Then we go at the lower level at regulatory. We've seen over the last 5 years, pharmacovigilance has emerged very strongly, not just in Uganda, but in Africa. And it has not just become a voluntary matter, it is now a compliance issue. Each institution with a distributor, with a product, needs to have someone who is responsible for the pharmacovigilance. And this is entry points for pharmaceutical care. So there's also need for deep regulatory engagement to realize that as we continue to think about strengthening medicine safety, pharmaceutical care is one way, because pharmacovigilance is more of a post-mortem. Pharmaceutical care is the pre aspect of it to prevent that from happening. Then as we move again at the facility level, the practice level, we need to ensure that pharmaceutical care is not just a standard of care for the pharmacists. It should become a facility standard of care. The guidelines should be able to support it, to ensure that we don't just have the clinical pharmacists there. We have them utilized and we have their impacts created and their impact seen. And then lastly, we also need to ensure the education. Yes, a lot has been talked about education. It is important to build capacity because we were faced with a challenge when we tried to structure to see how many clinical pharmacists are needed. We came up with almost about 120. But when you looked at how many are available, we realized we could actually not meet the training units and the numbers that had been trained so far could not meet the demand that we're trying to, or the positions that we're trying to fill. So it is very, very important that the whole design for policy should be like a conveyor belt design. You have the education unit that is churning out, you have the regulatory, you have the ministry, you have also at the national level. So in summary, we need to ensure that one, pharmaceutical care for NCDs is not just a pharmacist priority, but a public health concern, and we need to make it a political agenda. And it is something that we as pharmacists in parliament in Uganda want to drive it very, very strongly. Secondly, we need to ensure that at the budgeting level, the budgeting norms for medicines needs to be changed. It is not enough to budget for just the cost. You need to also, of the drug, you also need to budget for the cost of the pharmaceutical care service that is put. So that cost center, the norms need to be redefined. But also we need to redefine access. That access is not just receiving the drug. When you receive it, you've just received the product. When you receive pharmaceutical care services, you've received the drug. When you don't receive the pharmaceutical care services, you've actually received a poison and not a drug. So we need to redefine what access means. And then of course, we need to ensure that at the ministry level, the policies come out very, very strongly to support staffing norms. Organization public structure reviews need to be expanded. We also need to see more focus to provide training services at policy level, that these are priority health workers for pharmaceutical care services, and they need to be supported along those lines itself. And then lastly, we need to see regulation coming and saying this should not just be voluntary. This is a medicine safety issue. It needs to be an issue of compliance. And the facilities should not just see it as a pharmacy standard of care, but the facility standard of care. Thank you.
Yeah, thank you very much, Honorable Pio, and thank you. You're very comprehensive, and we like it that pharmaceutical Parliament Medical Medicines Forum is an innovation. Then you have also redefined access, and we thank you very much. Now, guys, I want to thank you all for your presentation. Now we have something like 7 minutes to be here, and I want to turn to, before I call Winnie to just greet us, I want to turn to Dr. Kamba to manage the rest of the things. Some tying loose ends that is seeing some very some questions which are really burning. 1 or 2 questions to any of the panelists. Kamba? Hello? Dr. Kamba, I'm seeing you. Dr. Kamba? Anyhow, I think maybe I stepped out, but yes, all of you have been very comprehensive, and all your presentations. I just at this moment wonder if there's any of you would like some clarification from any of you. Otherwise, I would like Winnie. Hello, Winnie.
Good morning, Professor.
Good morning. I'm sorry I didn't introduce you, but I said that you're lagging behind there and you're really managing us very well. I want to thank you for being there, for managing this with Professor Karen Beth. Yeah, you're our really golden thing we have in the department. So can you just say something before we close?
Thank you, Professor, for the opportunity to speak to the panelists. And I would like to thank each one of you for the time and dedication you've given to this session. And I'd also like to say thanks to the attendees. And one of the most important attendees I've just seen is Professor Nelson Sawankamba. It's a privilege to have you on our panel. And I hope the summit captures everything that has been discussed. And hopefully we'll have positive outcomes from the discussions. And maybe if any attendee has any questions, they could email them to the panelists. Thank you.
And we have some question from Florence Gitinji, and it says, thank you for the presentations. There's a lot of herbal medication coming up. Can this be integrated into pharmaceuticals? Anybody want to take that question? Hello? Joycelyn? Joycelyn?
Thank you.
I
was trying to connect. Yes. In fact, when we talk about NCDs and from the African perspective, a lot of people do use herbal medicines, but sometimes we hide our heads in the sand as pharmacists or in allopathic medicine by not acknowledging the presence of these herbal medicines. What should actually be encouraged now is whenever someone comes in and we're trying to help them to also understand their background, because we sometimes have these patients not taking their medications because they're taking herbal medications, and because they are actually embarrassed to tell the pharmacist or the doctor that they are taking herbal medicines. So it is important for the healthcare professional to acknowledge the patients we are dealing with, that they use herbal medicines, and then we also incorporate them into understanding their management. From different countries, I think now people are getting into registration of what we call complementary medicines, and more research should be going into that, so that we also look at even interactions, adverse events from these herbal medicines, so that the patients will actually get the benefit of these products. We have had some of our pharmacy students who have actually done postgraduate diplomas or PhDs in herbal medicines. One of my proteges, one of my young interns, has actually completed his PhD with herbal medicines for diabetes. And they found that there are these herbal medicines which actually work for NCDs. So it's important for us to actually embrace this aspect of a medical care so that our pharmaceutical care becomes complete. Thank you.
Oh, sorry. You didn't hear me. I was asking James, because he's working very closely with the community, and whether he has got any comment on that question of the herbal medication. It's really coming up in this pandemic. In Uganda here, you know what's happening, and there's a lot of debate on preparations, herbal preparations that because of the difficulty of COVID-19, it's coming up every corner of the country. And the herbal preparations are coming up, and there's a big debate on it. Manji, any comment? James, are you there?
Yes, James and Manji, I think, are different, but allow me to say a few things. Let me start by saying that my own grandmother, when I interacted with her as a small child, whenever I had any problem, whether a wound or abdominal pain or some headache, she would always have a solution. You know, she would either dash into some bush and come back with some herbs that she would chew. And, you know, for some reason, I got relief of whatever symptoms I had, whether it was just psychological improvement or not,
Yes,
I'm not sure.
That's
Yes.
all. We benefited from all our grandparents, our mothers,
Yes.
and when we talk in our group, in our peers, we say, how did we negotiate the diseases when we were young, because we all grew up in a village, and those herbs are really very important. But let me take this opportunity before these guys close us to just 10:30 to thank you once again very much for excellent preparations, excellent presentation and your topics, and managing to keep up. And I also want to thank the technical people, because yesterday, I understand, was a bit of fiasco in managing the technical setup of Zoom. We have managed to go through it without much problem today. So I want really to thank those people who helped us set it up. Professor Karen Beth and Winnie Nambatia, they're behind all this. And I hope we meet somehow in the future. Thank you very much.